Participants on the YouTube also, sir. Singaravadivel, sir.
Yes, madam.
Yes, sir. It's my proud privilege to flag off the university webinar series. Today we have Professor V. Singaravadivelu, who is a professor of Institute of Orthopedics, Madras Medical College. And we have two panelists, Dr. J. Parani, who is a professor and head department of arthroscopy and sports injury from Umandurar Government Estate, Chennai. And we have Dr. Tirunarayanan, professor of orthopedics from Keelpop Medical College. To introduce Dr. Tirunarayanan, I'm sure the orthopedic people will know it, but the others who are in the participant list, maybe I should tell them a few words about you, sir. He's Professor of Orthopedics, Madras Medical College, and a senior consultant in Noble Hospital and Wright Hospital. He's Vice President of TNOA. Past President of Madras Orthopedic Society. He has done his MS Ortho from Keelpop Medical College and PhD from Tnmgrmu University in 2015 itself. He has had about 11 publications in his PubMed indexed journal. In the state journal, he has around 8 publications. He has won a few awards. Yeah, he has presented papers in almost 100 national and international conferences. He has awards like the Best Doctor Award by our university, Best Doctor Award by the Collector, and Best Doctor Award by the Dean MMC in 2022. His areas of interest are trauma, management of difficult non-union of hip, pelvic fixation, and joint replacement. He has undergone a few courses, to name a few: international course on spinal surgery, advanced AO course. He is a faculty of international and national level joint replacement and fracture symposiums. At national level, he has plenty of courses that he has done. He has done a cadaver demonstration and also live surgeries. Over to you, sir. His topic for today is understanding the painful knee causes and its prevention. I think most of us have it already. Sir, and you can go ahead after your presentation with the panelists. After that, probably we can take up the questions in case there are any. Over to you, sir.
Sure, madam. So I'll start sharing my screen and
yes, sir, please.
Yeah. At the outset, hope you're all able to see my screen. You're able to see my screen, madam? Able to see my screen? Okay.
Yes, sir.
Okay. So, thank you very much, madam, for those words, kind words of introduction. At the outset, I wish to thank our respected Vice Chancellor and the Controller of Examination, all those people who are behind organizing this wonderful CMEs continuously for the benefit of so many people, because there are so many specialities which have evolved.
Sir,
in the
voice sir.
Kekliya, madam. I am unmuted only, and now you are able to hear me, madam?
Yes, sir. Now we can hear you.
But I don't know when I share my screen, anything is happening. Now you are able to hear?
Yes, I'm still able to hear it, sir. So I think it's fine.
Now, madam?
Yes, sir.
Okay, right, madam. So, thank you for the kind words of introduction. And at the outset, I wish to thank the M.G.R University, our respected Vice Chancellor and the Controller of Examination and others who are behind this wonderful CMEs being organized. The medicine has evolved so much and so many subspecialties have happened, and even in medical field, we don't know the next specialty, what is happening, and how to manage a common condition. So, with those words, I would like to go to my talk. The topic I chose was the common problem in us, every one of us, or people around us, will be the painful knee. So, shall we understand that the common problem and what are the reasons behind it and how can we manage it? So, if you see this patient, he has got so much of difficulty. He is otherwise a fit individual, and he has gone into this, and still he has been working, and he has gone into this kind of deformity before he came, and he was having so much of hesitation to undergo surgery. So there are so many myths and so many apprehensions in getting the treatment for knee joint. And if the knee joint is involved, which is very, very common, that affects our locomotion, ambulation, and that affects our quality of life. So the objective of this talk will be to identify what are the painful conditions and how to diagnose it, what are the treatment options available, and if there is any indication for surgery, what are the indications. So broadly, we can classify the painful condition of knee into a traumatic, whether it can be a ligament injury or a bony injury, or non-traumatic causes. So the traumatic causes we are not going to discuss here. There can be so many traumas here. And the most important thing which must identify is that the articular surface, the joint which is articulating each other, the bones which are articulating with each other, unless it is restored perfectly, then we will not get a perfect joint. So like this, if there is a bad fracture like this, where it involves the articular surface, the upper end of the tibia, the lower end of the femur, unless we restore it properly, then this patient cannot have a proper knee joint with full range of movement and painless weight bearing and locomotion. A ligament injury, it involves arthroscopic surgery or open surgery, and I'm the expert, and we have Tirunarayanan and Payani who are doing arthroscopic work. So this is posterior cruciate ligament, which is avulsed a chunk of bone, which we did 10 years ago with single screw fixation. Of course, it was by open method. And there's still the knee, you cannot differentiate with these two knees because they both look alike, apart from one metal implant inside. So when we restore the anatomy to its original, then as far as possible, then we'll be getting a painless knee. So what are the causes for a painful knee? Is it a worn out joint, the joint which is worn out by natural wear and tear? Is it an arthritis, which is a spectrum of disease which involves multiple joints, and is it one component of that? So should we take painkillers for knee pain, which should we take or not? What are the side effects we are worried? And should we stop exercise? When people are walking, they come and ask whether we should stop the exercise or should I start doing exercise? So these are the common questions. So if there is pain in the knee, what are the causes we have to identify? What are the risk factors and how to avoid that and prevent that? How to protect our joint so that it doesn't develop into a painful knee? What are the investigations we have to take and the treatment options? So that will be the course of this. So the causes for pain can be a polyarthritis, an inflammatory disease like rheumatoid arthritis or other ankylosing spondylitis, or so many things. It is a spectrum of autoimmune disease, so which can affect the joint, especially. So if it affects the joint, then that can gradually wear out, and if it is not treated properly in the initial stage itself, then it can lead on to a bad knee. So it can be an acute infection and painful, which is an emergency. If it is not let out within 6 hours, then it results in a permanently damaged knee. Trauma, of course, if it is not treated properly, then it can lead on to a painful knee. The other metabolic causes like gout and degenerative, which is the most common. So if you see this X-ray in this, so this joint is completely worn out. The bones have become osteoporotic. So this is an inflammatory arthritis, like a rheumatoid. And if this patient had been seen earlier and the disease modifying drug which have developed, the rheumatology specialty has developed so much, if it is followed sincerely without just depending upon the painkillers, then this kind of situation could have been avoided and this need not have happened. So there will be nothing much we can do apart from doing a replacement of the knee joint. So in the early stage, it has to be investigated, diagnosed, and management must be continuous. At that time, many patients come and ask whether I can take the tablets continuously. You don't have a choice to prevent all these things, then you may have to continue with caution. So then we'll deal mainly with osteoarthritis because these are all specialized subjects, and this osteoarthritis is one which is happening wear and tear, and how can we prevent that? So an articulate cartilage, we'll just see some of the anatomy, what it is. So it is a living sponge. Why? This is the empty space. When you take an X-ray and see, this empty space is the most important space of the joint. So this is not actually empty. So this is filled with cartilage, the meniscus, and the ligaments. So those things doesn't look white in the X-rays. That is why it looks empty. So this space gives us an idea whether the thickness of the cartilage is equal and it is sufficient for a painless knee. So this is a living sponge because it absorbs water when weight is borne by the patient on the limb, and the when the weight is borne, the weight water comes inside and it maintains the thickness of the cartilage, and weight is not, then it comes out. So the hydrophilic and hydrophobic properties it causes. So it acts as a shock absorber. So the water content along with the glycosaminoglycan, important protein, so which can protect the joint. But we must always remember that it is of limited supply. So we have to protect it. So if the cartilage is lost, almost it is impossible for it to regenerate unless we do some surgical procedures. Like now the orthobiological concepts have evolved, so which can regenerate, but those are all things which are surgical options, and it is not a good idea to look for that. So this is the anatomy, the articular cartilage. The hyaluronic acid is the basic framework over which the proteins and the water gets imbibed into it, which I was telling. So the core protein and the hyaluronic acid and the arrangement. So if you see the arrangement of the knee, so this is what the empty space looks like. This is the meniscus, which takes the stress, most of the stress, and these are the ligaments, the collateral ligament and the cruciate ligament. So what happens? This weight has to be distributed equally on both sides. But if there is due to some reason, if it starts bending, then one side the weight will be borne much, the other side will be lifted off, and this wear and tear will take place very fast. So the smooth, usually the cartilage is the least friction material which is available. The Teflon, we know that what we normally use in the kitchen. So it is almost 4 to 8 times smoother than the Teflon. So it is having less friction. Such is the nature's property. So if that gets worn out, then it becomes painful. So the epidemiology, what is the incidence of osteoarthritis? So when we see at the United States where we have little bit reasonable incidence, there are at the age of 30 itself about 3% have symptomatic osteoarthritis. By the time they reach 60, almost 40% have pain from the osteoarthritis and 80% have radiological evidence of osteoarthritis. And if you take the histology, almost 100%. So that is the evidence, the incidence of osteoarthritis. So almost in India, we can say with whatever data available. So what are the risk factors of osteoarthritis? One is age. There is tenfold increase when the person grows older from 30 to 60. Genetics does play a part, because some people say they are very thin and then even then they have an osteoarthritis. Those people who are obese, not necessary that they must have osteoarthritis. So there is some part, the cartilage survival, how long it is going to work for you, some genetic predispositions there. Women are more common. The nutritional aspect, low vitamin C and D, because these have come into prominence for almost most of the diseases, right? From malignancy to osteoarthritis, this vitamin D. And when we take it, is so unfortunate that though we have so much of sunlight, the vitamin D mostly from the skin, we need not take anything, it gets converted. All it needs is only 10 to 15 minutes of exposure. 3 to 4 days a week is enough for getting the adequate dose of vitamin D. But still, many of the people, they are when we test, we find that the vitamin D level is low. So those things can be avoided. But the exposure must be between when the shadow is very less, that is almost in the noon time. That is when you get the maximum vitamin D benefit. So the other causes can be the joint trauma, obesity, the occupation, so which involves loading the joint, abnormal joint biomechanics like some malalignment, some deformities. These are all the reasons which can lead on to an osteoarthritis. So when we take obesity, 50% decrease in osteoarthritis with just 10% of weight loss. So if a person is weighing around 100 kg, if they can just manage 10 kg of weight reduction, there is 50% decrease in osteoarthritis incidence, and the pain relief will be so much. So you cannot stress more than that if the patient has already had. So trauma is a very important risk factor. Once a trauma has happened, then the restoration of the joint, if the cartilage is involved, then it has to be brought back, or if the ligament is injured, then the biomechanics is lost. So it has to be restored. So that is very, very important. So if you see that if the trauma is not managed properly, so what should look like this? This can become like this if it is mismanaged, like a native treatment or anything. This patient may stand, the patient may walk, and the patient may almost do everything normally, but it wears out very fast. So then there may be no other solution other than doing a very complex knee replacement. So this has to be avoided, and in the initial time itself, when there is a trauma, it has to be managed properly. So once we have decided that the inflammatory, so first, what are the investigations? If the patient comes with a painful knee, what do? We find out whether it is any other systemic disease which is causing pain in the knee, or is it osteoarthritis primarily? Because the primary osteoarthritis of knee is more common in India than in other countries. where the primary osteoarthritis of hip is more. So when the patient comes, we have to find out whether there is any inflammatory component, whether the ESR is elevated, CRP is elevated, any rheumatoid factor, anti-CCP, and anti-nuclear antibody. All those to find out if there is evidence that multiple joints are involved, early morning stiffness. If it is there, then we have to do a workup for polyarthritis. If it is not there, if it is reasonably elderly or more than 60 with pain only in the knee joint, then we have to take an X-ray. So what sort of X-ray will go? Is there a need for CT or MRI? Many people, they come with MRI or they ask for an MRI. If it is beyond 60 or 65, and if there is no trauma, if it is not an acute episode of knee pain, there is no point in taking MRI, because when there is even radiological evidence of more than 80% in more than 60 years, no point in taking MRI, because a lot of degeneration will be there. It will be really alarming only for the patient, but it doesn't give any meaning. The meniscus may be degenerated, there may be some tears in that. The cruciate ligament, there may be some interstitial tear. So it doesn't mean anything, because by doing any ligament work, the pain is not going to subside, because it has come to a stage where the cartilage is involved and it will require attention only to that. So if it is an acute episode, otherwise fit person, and acute episode, then probably there is a role of MRI to find out whether there is any acute rupture with cartilage being normal. Otherwise, as a routine, taking an MRI is not indicated. So what type of X-ray should we take? So if this person, if the patient comes with this X-ray without weight bearing, this might look normal, or little osteophytes are seen, then it might look like a early grade, stage 1 or stage 2 osteoarthritis in Kellgren's grading. But if the same patient is bearing weight, so the same patient, you can see that there is no space here at all. Almost bone is touching the bone. So an X-ray, how it should be taken? So minimum must be, it should be a weight-bearing X-ray. So a plain X-ray on lying down supine position, it doesn't carry any meaning, because this might be masked. So the loss of cartilage, we may not see it in an X-ray, which is non-weight bearing. So this is very, very important. We have to take a weight-bearing X-ray. So MRI only after the X-ray. If it is an young patient, joint otherwise normal, it is indicated. Otherwise, it is superfluous or not needed. Now we'll come to the management. What are the aspects of management? One is lifestyle. So anybody who is coming with first time pain or pain which can be relieved, a weight loss, but it is very, very easy to say than do it. Even to lose 10 gram of weight, 100 grams of weight, it is so difficult. People come and say, I don't take at all, I am fasting almost all the time, and I walk and I do all the work, still I am not able to lose the weight. So there is lot more scientific uh, evidences have come, and a lot of development has happened. So you have to approach it scientifically for weight loss if people are serious. So people have managed to lose 10 to 15 kg, 20 kg just like that. So it has to be approached scientifically, just not by restricting the diet or by walking. We may not be able to. So just to say an example, if one person takes a glass of coffee, so he has to play a serious single shuttle match of 20 minutes to lose that calories. So people don't realize I'm just starving, but just a cup of coffee can give energy for 20 minutes of serious shuttle game. We can understand that how much of calories we take, because our body is so efficient in utilizing the energy. So we have to be very careful. Just by dieting, we may not lose. The exercise program next. So this is very, very important. This quadricep strengthening. So many of the time, the knee pain may be because of the patellofemoral pain. So the patellofemoral pain, the simple quadricep strengthening exercise will relieve that pain. So the patellofemoral pain can be diagnosed if a person has pain after sitting for 2 hours or 3 hours. When they get up, when there is pain, this we call it as a cinema sign, because once you watch a cinema and get up, you have pain in the knee. So most likely it may not be in the major joint, it may be in the patella. Or when the patient finds it difficult to climb stairs, especially climbing down, or sitting on the floor, squatting using the Indian toilet. If there is pain, that is more likely. So just a quadricep strengthening exercise will relieve that pain. Then range of movement exercise must be done. A low impact activity is most important. So many people, they want to reduce their weight, they are in a hurry, so they just start running and they come back with a very bad knee pain. So the most important or the best exercise I would say is swimming. Though the cardiologist may say running, climbing stairs, other things, it is very, very bad for the orthopedics. So swimming is the best because it doesn't load the knee at all. Then cycling may be the next best option. Walking is good, but walking on an incline, climbing stairs as a part of exercise, it is not good. Then, if it is not relieving, then an ambulatory assist devices. These things can unload the knee joint and that can relieve the pain. There can be some insole and unloaded braces, which I will tell you later. So, if you see that, what are the options which are existing for patients with having knee pain? So, it can be over the counter physical therapies, non steroidal drugs, and steroids, intra-articular. Only 19% are satisfied if they have knee pain. So these people will not be benefited by anything else other than a total knee replacement. But 81% who deserve a knee replacement are not ready yet. Maybe financially, probably mentally, they have a lot of apprehensions. Still, all those taboos exist. So they cannot have a TKR. So this is the gap what we have. It is waiting out the pain where it goes to a certain extent where they cannot do anything and then they have to get that knee surgery done. So, like the first patient who was trying to walk and so much of difficulty we have been seeing. Finally, they come to a stage where even going to the restroom becomes an issue ordeal. And when they get a knee replacement done just for going to the restroom, I feel that it is unfair for such a high-end procedure to be done only for using the washroom. So, what are the kinds of exercise? Coming back to the exercise, what are the kinds of exercise which are okay? Avoid further trauma, minimize running. It is wise to avoid high risk activity. You can always listen to your joint. So, if you're going to a gym, you want to reduce the weight, the trainer asks you to go on a CrossFit exercise for 20 minutes. Next day, they come with a patellofemoral pain because loading activities and highly resistant activities, these are all not good for the knee joint because it is going to add more pressure to the patellofemoral joint and also to the knee joint. So if the knee says that don't do that, then always listen to it, but don't listen to it continuously. It will not say anything. So you have to be very, very judicial. So what are the benefits from the exercises? So these are the levels of evidences. It is a 1A, regular aerobic walking, home-based quadricep strengthening, water-based aerobic exercise. So can I run? There are so many people who are coming and asking me. So the question that should be asked are your joints currently normal? Do you have any risk factor for the osteoarthritis? If you want to start your running from age of 40, I would say definitely don't do it. I want to do a long distance marathon. So if you have other risk factors also. So running has very significant benefits. It produces less obesity, less diabetes, less heart disease, less depression, better bone mineral density, everything. So moderate running in the normal joint, if you want to start at early age, it is really good. But at middle or older with risk of joint degeneration and with obesity to reduce weight, if you start, then you might come with a knee pain. So these are the insoles I was mentioning. So if you have and the outer aspect of the heel a little raised insole, so this will avoid the loading on the medial spine and it will reduce the pain. What are the other things you can have? TENS or acupuncture, ice therapy, all those things. So if there is a varus knee like this and the patient doesn't want surgery or they want to postpone, what are the things we can do? So this is the most common deformity, a bow leg. A lot of elderly people in our home also you would have seen. They have a bow legs like this instead of being straight. So what happens is weight is loaded only on one side, the other side is free. So this side becomes more and more worn out. So you can put unloaded braces. So these are the braces which will prevent loading on this side. So you put in a metal bar and then put some strap so that pulls the knee to this side so that this will open this side and load this side. So this is for patients who doesn't want surgery, constantly it has to be worn, or who are contraindicated to surgery. So these are unloaded braces. So these knee braces temporarily can be worn or it can be, if surgery want to be avoided, these braces can be worn. So, what are the medical managements? So, joint supplement, cartilage supplement like glucosamine, chondroitin sulfate, the acetaminophen for painkiller, the non-steroidal, the COX-2 inhibitors, opioids, and intra-articular injections. So, if you want to say about chondroitin and glucosamine, it can produce little glucose intolerance, but the levels of evidences are very less only, but it can be given in early stage. Intra-articular injection, the high molecular weight, the hyaluronic acids. So if the pain persists and the joint looks reasonably okay up to stage 2 and stage 3, It is almost like a synthetic, the hyaluronic acid, which I was showing in the normal anatomy, which you inject, the pain relief is there. So there are injections now which has come, single injection, which can last for 1 year. So 60 to 70% respond. Relief up to 6 months. So patients are satisfied. So intra-articular steroid, is it wrong? Many people have a big taboo about steroid. If you tell the name of steroid, people just jump and go, sir, steroid, I'll put on weight, or it is bad for the knee, all those things. So it is a temporary relief. Steroid at the place where it is needed, if it is given, it doesn't produce systemic effects. And what is the role or use? It doesn't have any really disease modifying role, but it reduces the inflammation and the pain relief is there. So if after 3 months, if the cartilage was biopsied and that has been studied, so even after 4 injections, 3 months interval, so later if the cartilage was studied, there was no permanent damage in that. So we need not unduly worried about intra-articular steroid, but the relief is temporary and doesn't have any disease modifying action. So these are the medical managements. Is there any surgical management? A young man with a bowed knee, if they come, so there is a procedure called as a high tibial osteotomy. So this deformity is corrected surgically, and weight bearing is made in the center. So if it is less than 60 and less than 15 degree of deformity, what can be done is, so this triangular piece of bone, the green shaded bone, is removed. A triangular, we call it as a wedge. It can be removed, and it can be closed. That bone can be closed. That part of the bone is removed. It is closed, so that what was bent like that, it is made straight. So once it is made straight, the weight bearing happens equally, and the pain is relieved. So this can be fixed like this. So if you see this patient, there is a varus deformity in this. He is around 40, 42. So he is not, but he was continuously having pain. He was not able to stand. He was not able to walk continuously. He was having difficulty. So the X-ray was taken. A line from the center of the hip to the center of the ankle, if it is drawn, it must be through the center of the knee joint. But here it is so much, it is deviated. So this is called as the genu varum. Then what we did is we just made a cut in the bone and we opened it so that this line falls in the center, and it was fixed. So once it was fixed, the weight bearing starts happening equally and the patient becomes normal. So this effect can last for 15 years, 20 years, and this is a very good alternative in the early stage. So if it is little elderly, a single leg standing view, there is no joint space, bone is on bone. So there is not much we can do about it. There is no cartilage. So even if you do a high tibial osteotomy, less chance. And if it is 55, 60, so he is just crossed that age. So what can be done? So this part is normal. So only this part is affected. So we can just replace only the component which is affected. And this part, when the cartilage is normal, need not be done anything. So this is called as a partial knee replacement or a unicondylar knee replacement. So what was just touching each other, just that part alone I did it. This is called as a unicondylar. And if you see this patient, this is the second post-operative day. Audio is there. So the patient started walking, and so the staff nurse was worried whether the patient is going to overdo. So this is the amount of pain relief the patient will have immediately on second post-operative day. This is another gentleman. So if you see, the varus has gone beyond certain limit, so much of varus, and he has so much of difficulty in walking, so much of bend. So the same patient, you can see how well he is able to walk once a total knee replacement is done. So if both the components of the knee joint, the medial and lateral, if it is involved, then a total knee replacement will be the right procedure for getting the relief. So people can wait up to this. So you can see whether this is knee joint or not. This is femur and tibia. You can see almost the femur has eroded the entire medial condyle. So both knees could not be taken in a single X-ray film. So it has to be broken and has to be taken. This is the weight bearing X-ray. So if it has come to that, then it needs little specialized procedure to create the bone, and we have to make it straight. So any amount of deformity, it can be corrected. So is there any age limit when you want this procedure to be done, when you don't want to do it? So this is an almost around 90-year-old person. He has come from West Bengal. So this patient wanted to walk. So both knees, he got it replaced. So this is the amount of function. So to conclude my talk, any person, so how to decide whether we have to undergo total knee replacement, who can be done, who is older, who is not fit enough. So any person who wants to walk, who wants to be independent, he is a fit candidate if he has got a painful knee. Who wants to walk is a candidate for total knee replacement. It is not the age. So no point of living like this. So what is the meaning of life? Is it just breathing and communicating? Movement is a very important component. If you don't see the outside world, only people who are walking in, you are going to see. So that may not be the right meaning for the knee joint. I mean, the life. So this is another patient. So is the physician's role is only adding years to the life? So you cannot confine yourself to that. It is also to add life to the years. So when bypass or anything else, if it improves the quantity of life, the replacement improves the quality, the way you are going to live. It is going to improve it. So with those things, I wish to conclude my talk. Thank you once again for giving me the opportunity. Thanks.
Thank you, sir, for that lucid presentation, sir. I think it was more for clinical the evaluation, sir. But can the panelists also join in and give their opinion, or they want to add on, or how does it go? You can just tell,
Yeah.
you can both of them, and probably they can just.
Good evening.
Yeah.
Good evening. This is Dr. Tnmgrmu.
Today your voice is little low.
Audible now, sir?
Yeah, you're audible.
Yes, sir. Good evening, madam. This is Dr. Tnmgrmu, ma'am. That was a very wonderful presentation, sir. I think you've taken us right through all the components of the reasons for the knee pain. So what ultimately might happen. So the basic doubt for the listeners and people between 30 to 50 is what about chondromalacia, sir? Like post pregnancy, and these kind of people also very commonly come into the clinics with knee pain. Young ladies around 30 to 40, they have just delivered, and so they also end up with a lot of knee pain. So can we call this as a precursor to many osteoarthritis, like something like a gestational diabetes? So people, they might end up diabetic ultimately. So are these chondromalacic patients are going to end up with the osteoarthritis? I think maybe the listeners would like to know.
Yeah, very well said, Thiru, that whatever you have told, exactly you have mentioned. So that is a warning sign, warning bell, which gives us that your knee started giving you trouble. So we have to spend, because more people are interested in diagnosis, more people are interested in the naming the disease, but people have to spend some time in the lifestyle changes. They have to do some exercises, and that is the time when it tells that there is some pain. They have to start doing some exercise, and if the weight is on the higher side, that is the time when they have to catch up. So the right modification of the lifestyle, doing some exercise and making it a part of their life, and then taking care of that joints, definitely that will come a long way and work for them.
Thank you, sir.
So
Thank you, sir.
yeah.
I think wonderfully you stressed on the importance of exercise. An exercise, proper exercise, not to overdo and get yourself injured, and the role of steroids, hyaluronic acid, and if at all necessary, even knee replacement without any apprehension. People can come forward and get the knees replaced, and they'll have wonderful, years of life. So the ultimate aim is not to get replaced, and even if there is, need, the definitely it can be done properly. So
Yeah.
I think that probably is the message that you want to convey to the listeners today, sir.
Yeah, that's true. Any other questions or anything from the participants, madam? Anything we can?
So young arthritics, what is the role of stem cell and PRPs? So I think that they have recently all the orthobiologics have come into vogue now. So can you just for the listeners, can
Yeah.
you explain the role of stem cell therapy and PRPs, which are coming more into usage now?
Yeah, it is more and more people have started doing it without having a proper evidence backup. So stem cell and PRP, definitely they have a role, but to whom I will say is that in an young patient, when an arthroscopic surgeon is going inspecting and he finds that there is some cartilage loss, and he wants to debride that defect and he wants to regenerate that cartilage, so he has to specifically inject in that place and put some gel there and then try the cartilage to regenerate. Just putting in, taking the blood or the bone mesenchymal and then concentrating and then injecting it. I feel that there is no evidence as of now. They just intra-articular injection. As of now, there is no evidence to say that it is going to help them. So these are all costly procedures, and I feel that people have to be little bit careful when they opt for it, because at any cost, people want to avoid surgeries. So for that reason, people go anywhere and anything people say, they just agree before surgeries. So I think they have to be little careful, and they have very very specific limited role for the orthobiologics people who are following it, and people who are doing arthroscopic examination. And if they recommend, definitely it must be done. But otherwise, just injecting into the joint doesn't have much role. That's what I feel. You have anything, Thiru, to add to this?
No, sir, not exactly. Actually, you have covered completely, sir. The entire spectrum of knee pain you almost covered. Maybe the young injured patients with meniscal injury or ACL injury, they might also need to check your knee properly in the physician, and if the ACL is completely torn or there is a meniscus root tear, definitely that might also need some surgical intervention. So I think the message is definitely avoid surgery, but where surgery is definitely indicated, I think they have to, without any apprehension and fear, they have to go get the surgery done and to add upon the life 2 years, as you said already, sir.
Yeah.
So I think I'll hand it over to the other
Yeah.
members also. If they have any doubts, I think they can definitely go and ask.
Sir, the other panelist has not come in, but just before
Yeah.
that, sir, is the range of movement full after the surgery is done, after the replacement is done? Is it the desired amount that comes back? That was one of my thing. And what will be the gap between the two knee surgeries that they can have, sir? These are general questions which
Yes.
quite a few patients ask.
Yeah, one is about the range of movement. Range of movement will be almost near normal, madam. 110 to 120. It depends upon the preoperative range of movement, what the patient was having. When the preoperative, people expect like preoperatively they'll be able to move only 80-degree, 90-degree. Postoperatively, they can have another 10 or 20-degree of increase. So who are having 60 or 70 and expecting 130 or 140, it is not realistic. That is number one, madam. Second, the range of movement, those who are having before, normally they can also have that normal, near normal range of movement, but they want to sit down on the floor, squat, or use the Indian toilet. That is not the same as sitting in the bed and getting the range of movement, because at that time we load unduly on one particular point of the replaced knee joint, so which can increase the wear and tear, and that can reduce the longevity. That is the reason we say that don't unnecessarily try to do all this, because many of the patients, they come with full range of movement, but we say that avoid the range of movement even if it is possible, so that your knee can come last. Second is that doing both knees together, or you want to leave a gap, you can leave a gap of 6 weeks if you are able to walk normally and there is little pain and you will be able to ambulate. But if both are grossly deformed like the knees which I have showed, even one knee is replaced, the other knee will not permit to walk normally. So if the anesthesia condition is normal, the risk factor is not much, then no harm in doing both knees together simultaneously. Thiru, you want to add something?
Yes, sir. Yes, ma'am. I think it's a very, very valid question, ma'am asked. I think, ma'am, ideally, it is better to give 6 weeks gap, as sir said. But even otherwise, people would like to get operated, because one anesthesia and managing the patient, managing other logistics are a little easier. I think that is the reason why people are going for both knees together. But physiologically, it is not ideal to get both the knees done at the same time. And definitely a 6 weeks gap is more ideal. But if as sir has said, if anesthetic complications are not there, there's nothing wrong in doing. But there are a lot of litigations and so many other cases also have gone through the court where the doctors have been reprimanded for doing both knees together. So that has also happened. So that awareness patients have now. So it's better to explain to the patient all the pros and cons and get their consent to get both the knees together.
So, and I have one more doubt. Like, if the sir said that age is not the criteria for replacement, so will it be necessary for them to undergo another replacement after 10 years or maybe 15 years? Is that a must, or will this itself hold good till they live?
The revision knee replacement, it depends upon how well you use and how well it has been done. So it is not that it is a must that after 15 years every knee should be revised. So the incidence is like 85% of the people, they have a survivorship, the present knees for 15 years. So if a person is around 60 and till 75, 85% of the people must not have any problem. And if there is a problem, the revision is there is a possibility and you need not bother. So there is a solution that you can be made to walk again. So our lifestyle, once the knee is replaced, they don't do that much like Western population where they want to do everything. They want to try everything, whatever is possible. So these people probably, they have a little increase in revision. But this is the incidence, and if there is a need, then it can be revised. But it is not always necessary that it should be replaced after 15 years.
Sir, and this is nothing to do with the knee. There are people who ask if there is a rod kept for a fracture, should it be removed or left in place, sir?
Definitely not necessary to remove any of the implant unless it is a child. So all those rods can be kept. Some people have a feeling that I have a metal inside, you please remove. Because of this, I have pain. Because of that, I have this problem. So only for that reason, if it is after 1.5 years and if the rod has served its purpose, then we can remove it. But not necessary that it should be removed.
Okay, sir. I think I have finished all my questions. In case anybody else who has questions, may feel free. Otherwise, thank you so much, sir, for addressing all of us. And we really gained a lot after this, because one of your prime patients probably is me, because I have both my knees which have OA. So
Okay.
I was quite this thing with all your
Definitely, you can look it confidently, madam. No issues.
Thank you.
Right.
Thank you, sir. Thanks a lot, sir.
Thank you, ma'am.
Thank you, Tirunarayan sir, as well. And
Thank you so much.
I think Palani sir has not joined. So
Yeah, he was in Chengalpet probably, and in NMC inspection, suddenly it has happened.
Oh,
So he was
okay,
not
okay.
able to join. That is the reason.
Right, sir. So can we call it a day then?
Thank you, madam. Thank you so much for the
Thank you
opportunity.
so much, sir. Thanks a lot. Pleasure having all of you. Thanks a lot, sir.
Thanks.
Thanks.
Thank you.
Bye, sir.